Good evening, everybody. It's 7:30 and I'm very pleased to welcome you to this evening's conference with the National Centre of Sport and Exercise Medicine on physical activity and maternal health. We have three excellent speakers and one very brave speaker slash patient who will be sharing their experiences. So we're going to be probing the evidence, the guidelines and the practicalities of what it means to advise women about their health as mediated through physical activity during, after pregnancy and at other points in that maternal health journey. Our first, I have a few housekeeping points. The advantage of Zoom is that there are no emergency exits to point out to you, but to ensure other aspects of smooth running this evening, please ensure that all your microphones remain muted and your video switched off. This talk is being recorded and will be made available online. So if you do switch on your video, you will be recorded for posterity on the recording. For questions, we're going to save those up to the end so you hear from all four speakers. If you have a question, feel free to put it in the chat at any time. So when the speaker's speaking, we'll collate those at the end and get through as many as we can before 9 o'clock. There are 1.5, inflating your CPD points for this evening for participating in this seminar. And to claim your points, please complete the feedback form and follow the instructions that will be sent to you in the next few days, along with information about where to view the recording from tonight's talk. So without further ado, I would like to introduce our first speaker, who is Dr. Hayley Mills. She is a sport and exercise psychologist by trade and director of the Perinatal Physical Activity Research Group at Canterbury Christ Church University. She's also part of the Chief Medical Officer's Physical Activity Communications Committee. Hayley, thank you so much for joining us this evening, and over to you.
Thank you. Let me just get things set up. Okay. There we go. Eleanor, can you just confirm that that's okay if I hit from... How's that? That all looks good.
That's it, yes. Do you want to show your video whilst you're speaking or not?
Yeah, that's fine. You'll have to tell me what I'm pressing.
I think you might have to start your video.
Let me just go here and see if there's more. Oh, there it is. There it is. Aha.
There we go.
Oh,
we can.
It's having fun. There we go. Is that better?
There we go. That's right. Thank you, Hayley.
Good. Right. Okay. Let me just click here. How do I get rid of that too? Aha. There we go. Right. Lovely. Thank you so much. Thank you for the introduction. It means that I can skip straight through to the aims of this session. So my plan for this session really is three different things. I'd like to raise awareness of physical activity guidance during and beyond pregnancy. I'm aware that there'll be lots of expertise in the virtual room from a range of disciplines and perspectives, but really it's the aim here is to unify those messages across the exercise and health professions so that we're all kind of singing from the same hymn sheet, so to speak. And then I'd like to signpost to some resources to support practice and further knowledge. So quite simple aims that hopefully we can get through. So really, overall, this session is about consistent, clear messages. Before I get on to that, though, I'd like to spend maybe one slide to try to explain why that's important, why there's such a need for clear and consistent messages. And within this area, we do see a lot of sort of inconsistency in how people are finding their information, how women are finding their information. I'll let you read some of these quotes. But things like used Google but didn't know who to trust. So what we're finding is that there's inconsistent sort of messages coming back from different professions and ways in which women seek their knowledge in this area, and they're not entirely sure what the trusted information is. And that's one of the issues that we find. And it means that women are left with some uncertainty and therefore less confidence to carry on being physically active. And we know that even those women that were active before do still find pregnancy to be a bit of a barrier because they're unsure. And we know that the research says that less than 15% of pregnant women actually meet the guidelines that I'm about to tell you about. So that's the reason why that we think this consistent messaging is really useful. So where are we up to with guidance? So if I take you back to 2006, we had a position statement from the Royal College of Obstetrician and Gynecologists, but we had no national guidance in the UK. When we get to 2017, we have the first Chief Medical Officer's physical activity guidance for pregnant women. And then in 2019, that is updated along with the other sort of resources in that. We also had the inclusion of physical activity guidelines for women after childbirth for the first time in 2019. Also, I'm going to take you through in 2020 an infographic, which is to do with guidance for returning to running postnatally as well. And in 2020, we also get the WHO guidance as well, which also has specific recommendations for pregnancy and postpartum. So, well, other than the WHO, it is a very sort of UK-centric version that I'm giving you here, just to take you through these types of resources. There is lots of other work out there and some really comprehensive work coming out of Canada and their guidelines as well. So there are other things out there, but this is sort of plan that I intend to talk you through today. So here we go. This being the infographic of the Chief Medical Officer's guidance for physical activity during pregnancy. Oh, I think I have a little pointer, don't I? Shall I try? Let's have a go. Laser pointer. Right, I'm going to have a go. So I think it's worth pointing out before I sort of pick up bits of it to say what this is for. So this is a tool for healthcare professionals, firstly, to use as a conversation. So the idea is that this infographic is there to help formulate a conversation with a patient at the time, rather than a standalone resource. So it is to promote those conversations, and those conversations are really important that go alongside this. But if we have a look at some of the key messages, if we have a look in the middle here, it's to accumulate at least 150 minutes of moderate intensity physical activity throughout the week. So that being the sort of central message in line with the adult guidelines. We also have muscle strengthening activities involving all the major muscle groups twice a week as well. Other things to sort of point out would be down here about every activity counts. So there is no minimum. Everything counts. We want to promote that it to be very achievable, and that just movement is important, and that we don't need to worry about there being any sort of minimum amount. Other sort of things to point out. So if somebody was already active before becoming pregnant, then we would like to say that they could keep going. So it's about maintenance, really. And yes, adaptation. We'll have to make some adaptations along the way, but we're trying to encourage some maintenance of physical activity here, and confidence that can continue. Over this side, it says not active, then start gradually. So this one sometimes surprises people, actually, because there's still a bit of a thought that perhaps if you weren't active before pregnancy that you shouldn't start, but actually the recommendations are that you now can, but gradually, and there are still benefits to be had there, and done as a gradual way that still is useful and ought to be encouraged as well. it is a gradual introduction of physical activities. Other things to point out. Oh, well, this is all about an uncomplicated pregnancy, but I'll let Amal later talk a bit about contraindications. I think that's better placed there, but this is for a non-complicated pregnancy. Other things to avoid prolonged periods of sitting, incorporating activities into daily living, all those types of things. If we look across the top here, this is where we see the benefits listed. These are supported by high quality evidence in order to appear here. So there's lots of research behind that. So if we have a look at some of these benefits, helps to control weight gain, helps to reduce high blood pressure problems, helps to prevent diabetes during pregnancy, improves fitness. The sleep and the mood benefits were ones that were adopted over from the adult guidelines as well, because of course pregnant women will get those benefits as well. Other sort of things as we go to point things out would be no evidence of harm. So there is no evidence of harm for healthy women maintaining moderate levels of activity. Of course, people do get concerned sometimes that might be an issue, that they could hurt themselves, could hurt their developing baby, but there is no evidence of harm. A theme that runs through this is adaptation, though, that we do expect things to adapt as the pregnancy progresses, and that changes will have to be made, but we can still maintain activity. And then don't bump the bump. So activities that have a sort of really high risk of say falls are not to be encouraged. Okay, we go on. Ooh, press again, shall I? There we go. So this is the infographic for physical activity for women after childbirth. You'll see that it's a similar sort of format to the pregnancy guidelines in many ways. We have the 150 minutes here as the kind of central landing point. Of course, it's really important to point out that this is a gradual build up to 150 minutes. So we're not expecting someone that's just had a baby to go straight back into that sort of level of activity, that it is very much a gradual build up. And even some people, when they've had, say, their 6 or 8 week check, might think, right, that's it, I'm back to 150 minutes. But that's not the case. This is the gradual build up to 150 minutes, so that that can be achieved later. So that's certainly worth pointing out. So some of the things to mention here. So if a woman's had a straightforward birth, activities such as walking, gentle stretching, pelvic floor exercises can resume really as soon as she feels up to it. So those really sort of gentle movement things can happen. After that 6 to 8 week postnatal check, then we can start to tailor the advice to the woman and the activity levels that she's previously had. But it is most definitely about a gradual build up, and again, no minimum. So it's, starting small is to be encouraged. We also have here, after having built up moderate intensity activities over a minimum of 3 months, and in the absence of any signs or symptoms of pelvic floor or abdominal wall dysfunction, the more intense activities can gradually start to be reintroduced as well. Okay, if I pop on, press it again. This is just pulling out those benefits and the safety messages a little bit more for us to see. So in this area, there's fewer high quality studies, really. So we certainly be encouraging people to do lots of research so that we can have more of these studies. But that said, these messages here are very much supported by evidence, so that we can see those. So there are really some very nice benefits that can come from women managing to be physically active after childbirth. Things like, that's written here, things like reductions in depression, improved emotional well-being, improved physical conditioning, reduction in the postpartum weight gain, and a faster return to pre-pregnancy weight, and it, again, improved sleep, which is kind of pressures when you've had a child. Safety, again, this will always remain a concern, but there is no evidence of harm for postpartum women that are doing moderate levels of activity. And also over this side, you can be active while breastfeeding. Again, that's something that we've heard of a few times, that women are concerned that if they're active, that they won't produce as much milk or not of good quality, or affect the growth of their child. But again, there's no evidence there. So that is, yeah, it's also safe. But yeah, depending on the delivery, because all women's birth experiences are different, and their pregnancies are different, and so depending on those things, we can start gently, and we can listen to the body and start our activities. But let's be very aware about sort of the holistic side of this, and how the pregnancy and the birth and everything around that has been for the women. That's why it's a conversation that we're trying to encourage with these infographics. Oh, I have to press a button again. There we go. This one is to do with returning to running. So this was led by some specialist physios, pelvic and running physios as well in the team, as a sort of an independent kind of set of guidelines. And then myself and my co-author, Dr. DeVivo, we went to a conference as well, and we had a lot of questions, and it was clear that people were really interested in how they can get back to running, how they can get back to that more intense activities. So we sort of teamed up in producing this that went into the BJSM. So it's very much a starting point. Again, there is not enough high quality evidence in our opinion, but we've the best that we can. There are now into these guidelines, and there is a lot of expert opinion in there as well. But if I start to show you what this looks like, here we go. So ideally, what would happen is that everybody would be able to see, say, a specialist pelvic health physio, and according to the NHS 10-year plan, that should be a possibility. But in reality, it's probably less likely. I think women that have an issue, perhaps they're leaking or have some sort of abdominal wall issue, that they might then seek that specialist help, but generally not everybody does it in reality. This is not hard and fast rules. This is about individual progression and sort of examples of how that might look to help people get back to running. Some people that are very active and very fit before might feel very, very ready to go back to high intensity activities sort of really quite quickly, but there is benefit from doing this gradually, and it should help prevent some long-term issues. That's what we're trying to get away from, is that in a few years time or in menopause or that there are more issues. So a gradual build should help prevent that, so that these things like leaking when running and things don't become normal. That shouldn't be the case, and hopefully with a gradual reintroduction that we should help that. So this is where this comes from. I'll let you have a look at some of the way that this is written out, and how we have the sort of the first sort of 0 to 6 weeks here, and some of the recommendations of the things you would expect to see, and then as we progress, what other sort of types of activities might get included, and then I'm going to show you the sort of screening that might then be conducted, which would then take us on to the next stage. If I do this one, there you go. This shows some of the screening that we would expect. So if someone's trying to return to running, we would want to know in the first instance if the mum is at least 3 months postnatal, and then we can start going through the process of using some of these measurement tools and a validated screening to to again look at the woman holistically and of all the different aspects and whether they are ready to progress to a graded reintroduction of running, or whether there's more rehab work that needs to be done. So this is one of the ways in which to encourage that sort of screening approach and a safe return to running. I've got my eye on the time, so I'm going to click on. I promised that I'd show you some resources and things moving forward. So here's some of those. You might already be familiar with the e-learning for healthcare sort of modules and things, the Health Education England program. So there is a module there that can be done, which is really, really good. It takes you through the guidelines in particular, unpicks things, asks you some questions along the way. So that's really useful. This sort of down here is a range of some of the things that I've perhaps referred to or that use the guidelines. But actually, if we go to the Active Pregnancy Foundation, that is very comprehensive. So it's a bit of a one-stop if you want to go and look for, or what are the guidelines, what are the resources, and that's for professionals, and that's also for women and families as well. So it's a really nice place to find all that information. But there are lots of other resources, programs out there, depending on your need and how much more information you would like. But I'd recommend the Active Pregnancy Foundation as a place to sort of go and find all that information in one easy, sort of digestible place. So, okay, I hope that's useful. I'll leave it up there for a second, but that's pretty much me done. Thank you.
Thank you, Hayley. That was a fantastic introduction, an overview of the evidence and resources there. Now I would like to introduce Dr. Lou Atkinson, who has been undertaking research into the determinants of maternal health behaviours for the last 10 years or more. She's a certified pre- and postnatal exercise instructor and a lecturer in psychology at Aston University, and she works with various UK and European organisations to develop and evaluate interventions and to educate fitness professionals. So Lou, thank you for joining us this evening, and over to you.
Thank you very much for having me, and thanks to Hayley for covering all of the really important guidance around how to be active. What I wanted to do with this session was to cover the evidence base for the emphasis on maternal physical activity, both during and after pregnancy, to understand really some of the challenges to supporting women to be physically active throughout their motherhood journey, but also to talk about the positives, or certainly what I see as the positives. So as Eleanor kindly said, I've been conducting research in this area for quite a long time. And the good news is that we have accumulated a really good evidence base around these influences. So we know quite a bit around what influences mothers to be active or not. So I want to cover some of that evidence around pregnancy and also around postnatal. So in terms of what the influences are, there are a wide range, and it's important to say that I've phrased it specifically as influences because these can be both barriers to being active, and they can also be enablers to being active. So depending on the individual woman, these might be a positive for them, they might be helping them to be active, or they might be hindering them to be active. So we can look at this in terms of something like the socio-ecological model, which looks at different levels of influence. And during pregnancy, a large amount of influence is intrapersonal. So we have a lot of individual factors that make a difference to whether that woman is going to be able to be active or feel that she wants to be active. So if you've ever experienced pregnancy yourself, I haven't, my knowledge is completely theoretical, but I have spoken to thousands of women, and one of the key things they always talk about is feeling fatigued. For some women, that changes as the pregnancy progresses. For some women, it's a feature, and obviously some women will cope better than others, but it is something that is really, really important to understand before we start actively encouraging women to be more active. Related to that are the whole plethora of pregnancy symptoms and discomforts that a woman may experience. So that could be low back pain, it could be an inflamed pelvis, it could be things like constipation, incontinence, all sorts of different experiences women may have. Now, for some women that may be preventing them from being active because they don't feel comfortable, or they don't know how to be active without aggravating those issues. For others, for other women, they will use activity as a way to alleviate some of those discomforts and cope with some of those symptoms. As Hayley has very eloquently touched on already, a big factor is going to be concerns about safety and the knowledge of which activities are suitable, and a common phrase is it's good for pregnancy, or I wanted to know what was right for pregnancy. And as Hayley's explained, there isn't really anything that's good or bad for pregnancy. It's just about working with the individual body and requirements. But again, women are going to prioritize safety first, and they are likely to take a precautionary approach. And that's one of the reasons why we tend to see a big drop off in physical activity pregnancy. In the absence of confidence in their knowledge about what is safe and what isn't safe, women will likely withdraw from most activities. We have practical, pragmatic factors like time, how much time women have available if they're working, if they have other children around, they have to look after, other responsibilities. So very practical concerns. And then differences in motivation. So as I said, women will prioritize things that they see as beneficial for their health, but particularly for their developing baby's health. They may be motivated towards managing their weight during their pregnancy and using physical activity as a way to prevent excessive weight gain. But also we know that some women feel that pregnancy is a time when they don't have to worry about their weight. There's an awful lot of social pressure on women around aesthetics and around weight, and sometimes women feel that this is a time when that pressure is alleviated, and so they want to relax and enjoy it. And there's also a perception in some women that it doesn't matter if they don't exercise so much during pregnancy because they'll do it when they've had the baby. So again, it's a time to take off from their activity habit perhaps. And also their individual confidence around physical activity and particularly an exercise habit before, or they see being active as a key part of their identity, those women are more likely to pursue activity during their pregnancy. If those things aren't present, they're less likely to do so. On an interpersonal level, what we see is that the support of the people around women can be hugely influential. If partners are active and are supportive, if friends and family around them are generally active, we'll see the woman is stay active more often during pregnancy. If the people around them are less positive about the idea of being active during pregnancy, then they're less likely to be active. Advice from professionals is absolutely crucial. It's one of the reasons why those guidelines being in place and being consistent are super important. We know that women particularly will look to their midwives during pregnancy as the fount of all knowledge, and they will listen to what those professionals are telling them. So if the professionals are not feeling confident about giving advice, then again, the women are likely to take a precautionary approach to reduce risk. Whereas if professionals are really confident and able to give very good specific advice, women are more likely to follow that advice. As I said, the sort of social norms around the women are very important, and that includes things like cultural practices. So we know in certain cultures, activity is discouraged during pregnancy. It's seen as a time to rest. It's seen as a time to nurture. And again, there are likely to be higher concerns around safety in certain cultural communities compared to others. And we have the influence of work and caring commitments and the need to fulfill all the roles that pregnant woman has. And then further out from the woman herself, the environmental aspects. I'm sure many of us all feel the same. If we like to go out for a run, but it's raining, we're likely to put that run off. So if you happen to have your pregnancy during the winter months, that may well affect your activity levels. But primarily this is around access to facilities and resources, where there are green spaces that are considered to be safe, where there are access to classes and instructors and facilities. Women are more likely to be active. And one of the things that comes up time and again within the evidence is the desire for pregnancy-specific programs. So where those are available to women, they are more likely to take advantage of those and to maintain their activity levels. So hugely complex set of factors. Before we move on to postnatal, I thought it might be interesting to share with you a brief insight into some work that one of my PhD students is doing, particularly around the area of social support, because this is something that not only is very prevalent in the research around what influences women's activity levels during motherhood, but it's something that is potentially modifiable in terms of interventions. So this is a huge systematic review that Becky Livingston has conducted, and I couldn't possibly do it justice in the 1 minute I'm going to give it here. So I'm just going to specifically talk you through what she found, some of the things she found around social support. She's also looking at social power, but she identified 50 qualitative studies, which she synthesized. I'm so glad she did, because I wouldn't have the time. And she's coded all of the different people that are mentioned in terms of providing social support for women to be active during pregnancy. So I thought it just would be interesting to see who they're citing as influences and who they're citing as sources of support during pregnancy. And sometimes these are positive and sometimes these are negative. So just to briefly highlight that, as you can see, health professionals are by far the most referenced group, but also dependents, and that includes other children and the unborn baby, and particularly the maternal family and their partner. And that's likely to be more influential because of the proximity to the pregnant woman, so they have access to those people and they're in contact with those people a lot, and also because those people are perceived to have an investment in the pregnancy. Lower down the list comes information sources, exercise companions, gym and exercise professionals. And it's seen that these people have utility in terms of enabling physical activity behaviour because they're perceived as having expertise. And lower down the list are people like non-exercising friends, other pregnant women and work colleagues. But what's particularly interesting is that people, which are sort of acquaintances, strangers, members of the public, are higher up the list than some others. So we see that there's a significant influence of society as a whole, and particularly how society perceives what pregnant women should and shouldn't be doing. In terms of postnatal, in a similar way to the guidelines that Hayley was talking about, we do have less of an evidence base around what influences women after pregnancy, but there is some really good research out there, and we'll see again some of the similar factors coming through in terms of the intrapersonal. So there's the physical body and how well that's recovered from birth, what type of birth experience they had, and the physical limitations that pregnancy and childbirth will have brought about in terms of them resuming exercise. But there's also the prioritization of child and home, and that's partly around wanting to bond with the child, wanting to develop that mother-baby relationship, but there's also a bit of social pressure in there sometimes to be a homemaker and to be seen to be being a good mother by prioritizing spending time with the baby. And there's a desire not to disrupt baby's routine by handing baby over to somebody else while the woman goes out and does some physical activity. There's also sometimes some perceptions that when you are a new mum, you are very active all the time, you're very busy, you never get time to rest. So the idea of then purposefully doing exercise can seem a little bit counterintuitive. Motivations, again, we see change through that postnatal period. So whereas women might have perceived they'd be quite motivated towards physical activity during pregnancy, they find that isn't always the case. Whereas for some women, they are very keen to get back into their exercise routine, re-establish their identity, and perhaps also looking at weight management and returning to pre-pregnancy weight. And of course, there's the practical elements around, do they have the time to do it, and do they have the energy to do it in their sleep deprived state? We still see social support as hugely important, but maybe spreading a little bit wider than just that immediate partner and family, and actually the social network. So whether they have other mums of young children who they can be active with. And environmental factors still come into play. So again, a really key thing here is access to facilities and resources, including whether they can have childcare as part of that. And also, similar to pregnancy, wanting programs that are specific to postnatal to reassure them that they are safe, they are appropriate, and that the women are going to find them useful. So I wanted to very briefly touch on intervention research, given that we have this evidence base around understanding all of these influences and perhaps how we could leverage those in order to support more women to be more active. Our intervention research so far has not been terribly successful. And I say that as someone who's been involved in lifestyle interventions during and after pregnancy. So I'm part of the problem for sure. So a recent systematic review looking at interventions for physical activity in pregnancy found that only 5 of 15 were actually effective at increasing physical activity. The authors also looked at what types of behaviour change strategies were used, and they found that mostly it was informational and instructional strategies. And that might give us some insight into why these interventions are not being as successful. If we look back at those factors, and I'm going to go through that in a second, maybe it's not about knowing, maybe it's about finding ways to overcome some of those more complicated barriers. Similarly, after pregnancy, another recent systematic review found that lifestyle interventions generally were effective at increasing physical activity postnatally, but when we drill down into the behaviour change strategies, there wasn't any clear indication of what strategies, what behaviour change techniques were actually useful. And so the conclusion that we can draw from that is that what we need to think about is how we can provide flexible and tailored support, perhaps on a more individualised level. So as I said, if we think about how we could use the knowledge that we have and translate that into supporting women to be more active, we could use something like the COM-B model. If you've come across the behaviour change wheel from Susan Mickey and colleagues, you'll be familiar with this. I obviously don't have time to explain it all to you, but it's a simplified version of a number of health behaviour change theories. And just doing a little bit of analysis based on that evidence base, we can see some of the ways that we might want to influence some of these aspects. So for example, if we want to increase a woman's capability, both her psychological and physical capability to be active during and after pregnancy, these are some of the things we might want to look at doing. So we want to make sure that the woman knows what to do and how to do it, with an emphasis on safety. We also want to be able to provide tools to improve behavioural regulation. So when we see that there's already high levels of motivation, actually what happens is that, all of us have the same problem. We forget, we have a form of good intention, but we don't form a specific plan. And so we don't follow through on those good intentions. So tools, simple tools, can help to follow through on those good motivations. And also providing simple and adaptable activities that can be adapted to the physical state that that woman is in at that time. So if things are a bit sore, if she is a bit tired, finding things that she can do that she feels capable of doing. In terms of motivation, really the key things here are emphasising the benefits for the baby, not so much for the woman. Even after pregnancy, really the priority is still the baby. So we need to talk about how the mum being active benefits the developing fetus and develops benefits the family as a whole. We really need to address the myths, and that's not just the myths around safety and what exercises and activities are good and bad, but also some of the other myths around again, sort of, social norms and what's normal. And in terms of motivation, women are always going to be more motivated to do things that they find fun, and also that improve their overall well-being. So we need to address this connection between physical activity and weight management, and perhaps emphasize how it helps mental health, not just physical health. And we can increase opportunity by providing practical support. Some of the interventions that have been successful have been around providing exercise equipment, for example. And as I've mentioned already, social support is something that is really, really important. I'm already over time, so I'm going to just skip through some of these things. Luckily for you, there's a paper you can read that will explain a little bit more, but I wanted to draw on some of the thinking that myself and Hayley and some of the other people that I work with have been thinking about in terms of the disruption that we've had to our lives as a result of the pandemic, and maybe how we could turn those negatives into a positive. So if we think about some of those influences, lack of time, the difficulty fitting it into your life, the idea that you have to go to a specific class in order to be safe. We now have women who are potentially working from home, not commuting, and so might have a little bit more time to spare, or at least a little bit more flexibility about when they fit their activity into their day. And we have the Joe Wicks effect. So online workouts, virtual workouts now are something that are much more acceptable to women and to all of us. And one of the things that I've been part of, along with some of my colleagues at the Active Pregnancy Foundation, is compiling, collating some really good quality resources that women can feel that they can access and they'll be safe. Similarly, as I mentioned already, there is a big reliance amongst women on their healthcare professionals, their midwives, their health visitors, their obstetricians. And of course, that's appropriate because these are the medical experts. But we know that all of these people are incredibly busy, and the evidence shows they don't always feel confident to advise on physical activity. And so this disruption to the normal provision of antenatal and postnatal care means that perhaps women might be more likely to seek advice from different but just as credible sources. So things like online experts in postnatal physical activity, and also being able to access more classes either online or actually outdoors and in person. I touched on mental health briefly. One of the interesting things that we found, the Active Pregnancy Foundation ran surveys during lockdowns, and they found that pregnant women and postnatal women, were almost all of them were using physical activity as a way to cope with their mental health during the lockdown and during the pandemic. So again, I think a way that we can move forwards is that we can emphasize to women and the people around them that being active is really important for their overall well-being, and to help them cope with the pressures and the stresses of pregnancy and motherhood. And the last area, and I will let you go, is around health inequalities. So we know that women who live in deprived neighborhoods, who have lower incomes, are not being reached by some of the traditional interventions that have been implemented already. Similarly, women from Black and ethnic minority backgrounds are less likely to engage with the interventions that have been trialled so far. And we also know that women who are pregnant, who have obesity, are less likely to be active, and are also another group where it has been traditionally more difficult to engage them in interventions. So we have this opportunity now with our world, with our bigger focus on health inequalities, and with the impact, the long-lasting impact of COVID, that maybe we can bring more focus into reaching some of these women and helping them to be more active. As I said, this is a paper that myself and Hayley and colleagues wrote that you're very welcome to read if you want a little bit more information around some of that positive thinking. That's all from me. Thank you very much.
Lou, thank you. That was a fascinating look at the influences there. Just a reminder to everyone, if you've got any questions, do pop them in the chat. You can address them to everyone. It may help stimulate questions and avoid repetition. If you have already put questions in and they've gone to NCSEM East Midlands, that's fine. We've got them. You don't need to resend them. So now I would like to introduce Dr. Amal Hassan, who is a senior registrar, soon to be consultant in sport and exercise medicine at Imperial Trust, and also a senior clinical teaching fellow at University College London. Amal is a passionate advocate of maternal health, and this permeates her clinical practice and her academic work. She's on the scientific advisory board for the Active Pregnancy Foundation and is co-founder of the pelvic health digital education platform. So Amal, thank you for joining us this evening, and over to you.
Thank you very much for having me. As I'm sharing my screen, I'm just going to alert everyone to the fact my husband is struggling with 2 very small children upstairs, so we may be able to hear them at some point, and I'm very sorry if that happens. And also my internet is being extremely unreliable. I have come all the way downstairs to be near the router, but if I cut out, I'm really sorry, but I will be back as I have done throughout this call already. So it's a pleasure to be able to present on this topic. And just before I start as well, I want to just reiterate, I am not an obstetrician. I come from a sport and exercise medicine background. So if you do have any questions relating to the more obstetric side of pregnancy, I'm afraid I probably won't be able to answer those. So just to alert you to that. And also just linking into the presentation that we've just heard. Thank you, Lou. This presentation really links into that, what to do and how to do it safely about exercise in pregnancy or activity in pregnancy. And so I'm going to make a call for action here and suggest, with respect to complex pregnancy or pregnancies that are complicated by contraindication, that our approach to physical activity guidance is modification and not cessation. So we've had physical activity guidelines, as Hayley has already presented on, since 1985, and they were initially published by the American College of Obstetricians and Gynecologists. And there's been an explosion of literature demonstrating the benefits of prenatal exercise for the health of 2 generations since, where no contraindications exist. But despite this shift in attitude away from rest is best, physical activity levels have consistently been shown to decline during pregnancy, and that is regardless of pregnancy-related morbidity or existing conditions. As it's already been alluded to, cross-sectional studies have already estimated that the engagement with physical activity in pregnant individuals is around 3 to 15%, and that is compared to up to 58% in non-pregnant women, depending on the data that you're looking at. Perhaps unsurprisingly, the rates at the same time of pregnancy-related complications that exercise in itself might help prevent have been increasing over the last 4 decades. And on the screen there on the left, you should see the rates of hypertensive disorders of pregnancy increasing, and that's CDC data from the United States. And on the right, the rates of essentially gestational diabetes rising in the UK. Mounting pregnancy morbidity obviously has been a recent concern given the COVID-19 lockdown. And Lou and her team have demonstrated the deleterious effect of lockdown on physical activity levels in pregnant individuals, at least in the United Kingdom, but we have evidence as well from North America that reflects this. And yet we have really demonstrated, we've come a long way in demonstrating the benefits of physical activity in pregnancy, being able to decrease the odds of developing major pregnancy complications by approximately 40%. And those include gestational diabetes, preeclampsia, gestational hypertension, and the risk of having a big baby or macrosomia, as well as decreasing the odds of developing prenatal depressive symptoms by up to 70%, which is remarkable. Critically, these benefits occur without increasing the risk of having a miscarriage, a small baby, or preterm birth related to activity within the recommended amounts. And this recommendation carries over to pregnant individuals who are overweight or obese. And despite particularly these known benefits, there remains a subset of pregnant individuals who are cautioned against activity due to a variety of pre-existing or pregnancy-specific conditions known as contraindications. And this advice may come from the medical establishment or simply from family or friends, or be intrapersonal, as Lou was explaining, in the absence of other reassuring knowledge. So I think now would be a good time to recap our knowledge of the physiology of pregnancy and the adaptations of physiology in pregnancy. I'm going to focus on the uncomplicated pregnancy, and I think it's good because it helps you understand why certain conditions may require limitations on the intensity or type of activity that are undertaken during pregnancy. But I'm just going to focus on cardiorespiratory adaptations tonight. Ultimately, what it all boils down to is the fact that the physiological changes that do occur are designed to optimize uteroplacental circulation and materno-fetal gas exchange. So you may recall from the physiology that you have done in your own training, if you have, that maternal circulation during pregnancy becomes what we term high flow, and that's due to circulating progesterone and estrogen, prostaglandins, and other vasoactive substances, and also as a result of the low resistance uteroplacental system itself. Maternal systemic vascular resistance reduces by 35% at 20 weeks, but ultimately increases to a 20% overall reduction at full term. The renin-angiotensin system will then be activated as a result, and that leads to an increase in plasma volume, and that contributes to an increased total blood volume by 50%, representing an extra 2 litres by 35 weeks gestation. Cardiac output is increased by 8 weeks, and it reaches an extra 35% by the end of the first trimester and an extra 50% by the end of the second trimester as a result of increased heart rate and stroke volume. And by term and at rest, the uterus receives 10% of maternal cardiac output, and this needs to be maintained during activity. And thanks to those adaptations, it is protected. Some cardiovascular considerations to take into account during exercise prescription would be that despite the greater cardiac output at rest, the maximal cardiac output during exercise is attained at lower work levels. And although resting heart rate is higher during pregnancy, maximal heart rate is lower by late pregnancy, and this translates to a lower heart rate reserve in the later stages. Finally, RPE is also an unreliable marker of heart rate during activity or exercise in pregnancy. It's recommended RPE is a reliable marker of work rate, as you are likely to underestimate the true value. So heart rate monitoring, particularly in athletes, is very important. And then in terms of respiratory adaptations, the functional residual capacity reduces from the second trimester, and that's largely anatomical through splinting of the diaphragm, reaching only 25% of the pre-pregnancy values by term. But to compensate, minute ventilation increases from early pregnancy to 140% by term, reflective of the increased tidal volume and increased respiratory rate. This is due, so the increase in the respiratory rate and minute ventilation is thought to be due to a maternal sensitivity in arterial carbon dioxide. And this is possibly designed to protect against fetal acidosis. So again, this fetal-maternal gas exchange is paramount, as the fetus itself cannot excrete carbon dioxide. So the resulting mild maternal respiratory alkalosis allows that diffusion of fetal carbon dioxide across the placenta. And the increased minute ventilation also increases maternal arterial oxygen tension as well, which again benefits both mum and baby. Oxygen uptake, or your VO2, and minute ventilation will continue to be increased during submaximal activity, and VO2 increases in proportion with maternal weight gain. And pregnant individuals may experience slight shortness of breath on exertion, although this is generally perceived to be reduced during steady state submaximal activity. So hopefully from that, you can appreciate how certain, particularly cardiorespiratory conditions, whether they be pre-existing or a pregnancy-related complication, may negatively impact on uteroplacental circulation and maternal-fetal gas exchange and we'll come to the contraindications themselves in a couple of slides' time. But I'm not going to go into this because Hayley already did. We know that exercising within the recommended amounts here on the screen can lead to a 25% reduction in the risk or the odds of developing gestational diabetes, preeclampsia, gestational hypertension, prenatal depressive symptoms, and excessive gestational weight gain. But although we, on the whole, say as clinical professionals are becoming increasingly aware of these guidelines, it remains the case that for those with pregnancy-related contraindication, i.e., as Hayley pointed out, these guidelines relate or are applicable to those without contraindication. Those with pregnancy-related or existing medical morbidity have an increased risk of either receiving poor guidance or none at all because they don't feature, for example, in this infographic. Now, perhaps contributing to the inconsistencies in guidance given by healthcare professionals, as Lou was pointing out, is that although most guidelines for prenatal exercise do have lists of, they include lists of contraindications, the categorization within them is variable, and there is a lack of specificity or even availability of exercise prescription advice for these specific conditions. Interestingly, for many contraindications, it's recently been suggested that there is no evidence demonstrating improved pregnancy outcomes as a result of disengaging or not beginning to engage with physical activity, and most have been found to be based on expert opinion and are possibly outdated given new empirical evidence that demonstrates the range of physical activity associated benefits in pregnancy. And it's worth noting here that when we talk about physical activity, it's an umbrella term. It encompasses a variety of physical movements and behaviours across a spectrum of intensities. So whether they be sedentary behaviours like lying and sitting, to light walking or activities of daily living, to moderate and vigorous activities, including structured exercise. And you can see here from this infographic from the WHO, the activities realistically encompass a range of purposes from caregiving, occupational, travel, and leisure time. And it shouldn't necessarily be the case that you are either given the green light to exercise or you are precluded from all exerting activities simply by nature of the physiological complexity or simplicity of your relative simplicity of your pregnancy. And the lack of available guidance depending on what your contraindication is. And I hope that in the near future there will be more information about this. So the publication of this particular paper by Margie Davenport's team in Alberta, Canada is extremely important, and given the rise in the pregnancy-related complications, very timely. And what it does is call into question the evidence behind the current or common current categorization of contraindications to exercise in pregnancy. And their review set out to examine the impact of both acute and chronic exercise in those with contraindications to identify potential benefits that perhaps we haven't been focusing on in the past, all risks to maternal fetal health, and propose new classifications for relative and absolute contraindications. And in doing so, removing some of those barriers to physical activity in these groups of women where appropriate. So I have just summarized the new proposed classification from this group on this slide. And you'll see some cardiorespiratory disorders that you might want to just think about in your head with respect to your refreshed knowledge on the normal physiological adaptation in pregnancy and how maintaining the utero-placental circulation and maternal-fetal gas exchange is paramount to how some of these disorders might impact exertion in the context of that changed physiology. So on top of that, at the same time, I'm going to introduce to you how they've reclassified these conditions. So they identified 10 conditions for which engaging in regular, moderate, vigorous physical activity did indeed demonstrate a strong potential for adverse effects for the mother and or the baby, and they are classified as absolute contraindications. However, they also indicated 10 disorders for which the evidence suggested modification of activities, reduction in intensity and duration or volume, and specific movement adaptation over complete cessation, and listed them as relative contraindications. And based on available literature, they found that 11 of the previously or traditionally listed contraindications should no longer be considered a barrier to being physically active at all within the recommended amounts. And I think of interest in that list particularly will be those with a history of spontaneous preterm labor or a history of fetal growth restriction in a prior pregnancy, anemia, a high order pregnancy, recurrent miscarriage, and gestational hypertension, chronic hypertension. So I think that's a really interesting finding. Women with absolute contraindications are of course discouraged from engaging with moderate to vigorous physical activity due to the strong potential for harm. However, these latest guidelines advocate for continuation of activities of daily living, i.e. light walking, light cleaning, cooking, a very domestic set of activities, due to the known adverse effects of activity restriction, i.e. bed rest. And that brings me on very nicely to the notion of bed rest. So traditionally, women who developed contraindications during pregnancy and were categorized as high risk, these women have been, or individuals have been, prescribed a severe form of sedentary behaviour, which is known as bed rest. And unfortunately, data from comprehensive meta-analyses have shown no benefit of bed rest on pregnancy outcomes and an increased risk of preterm birth when prescribed to pregnant individuals in developed countries. Empirical evidence suggests not only that bed rest induces negative impacts on maternal health, such as anxiety, depression, muscle atrophy, bone loss, venous thromboembolism, and that's independent of obesity being an additional risk factor, and gestational diabetes, but that fetal outcomes are not improved, with some evidence suggesting that in developed regions of the world, earlier delivery may occur as a result. Nevertheless, more North American data suggests that up to 93% of physicians will prescribe bed rest for high-risk pregnancies. And that's for lack of a better therapeutic option. Of particular concern, the majority of those prescribing physicians do not provide any recommendations alongside for rehabilitative exercise, which may go some way in alleviating the negative side effects of activity restriction. This is interesting, but recent research suggests also that pregnant individuals who are hospitalized but are not placed on bed rest are likely to effectively bed rest themselves, being sedentary for up to 91% of the day. And if anyone's worked in a hospital or been admitted to a hospital, it's not difficult to think why that might be. Certainly hospitals have been shown not to be the most conducive environments for a physically active day. And again, interestingly, I'm picking up on something Lou said towards the end of her presentation, not pregnancy. This behaviour is not only seen in hospitalised pregnant individuals, but even those with uncomplicated pregnancies, and that's likely to be demonstrative of the sheer number of perceived reasons why pregnant women don't feel able to be physically active, or pregnant individuals don't feel able to be physically active. And again, as Lou was saying, healthcare professionals and clinicians are reportedly one of the most important sources of information about physical activity in pregnancy. And unfortunately, a recent study has shown that we are very bad across the board at giving physical activity advice to pregnant individuals that is accurate and evidence-based. So I think it's important for us as healthcare professionals to discuss this, and we need to talk about it with all of our pregnant patients and contacts. We need to make sure that we're having those conversations, importantly, with respect to this talk, regardless of complication or comorbidity in a pregnancy. Because there is likely to be some form of activity that any pregnant individual can engage in, regardless of how high risk the pregnancy is. But of course, those discussions need to be had on a multidisciplinary team basis. So my resounding and conclusive message is that we should be encouraging pregnant individuals with contraindication, whether they be relative or absolute, in collaboration with their obstetric healthcare provider to help them modify but not stop being physically active, and also to begin, if they haven't done any before, working towards the levels that we perceive, to the best of our awareness, with the best available evidence, is safe for them, within the threshold of their symptoms and objective medical signs. And just a reminder that even physical activities below the recommended threshold can have substantive health benefits, even for pregnant individuals. So simply going for a brisk walk for 10 minutes reduces the odds of developing preeclampsia by at least 25%, and bumping this up another 5 minutes per day also reduces the odds of developing excessive gestational weight gain during pregnancy and gestational diabetes by 25%. So every little really does help. I've pretty much summarized my conclusions, but just to reiterate, we're working towards being able to advise pregnant individuals on physical activity regardless of contraindication across a range and spectrum of intensities, encouraging the facilitation of discussion, and I'm making, alongside many others, including those tonight, a call to action for more research on physical activity interventions, particularly in complex pregnancy, to demonstrate safety. And I'd just like to acknowledge Margie Davenport, Vicky Mia, Greg Davies, and Professor Sakos at UCL for their help in enlightening me on these topics. I've got references if anyone's interested as well. Okay, so I am going to lead us into our final discussion, and I am going to welcome Rhian Stevenson, who is somebody I know and have worked with in the past, but is also somebody who's had a very interesting journey through pregnancy relating to physical activity. She is a coach, works in health and fitness, and has a background as a competitive athlete, so has kind of crossed the spectrum of athlete and occupational exerciser. So Rhian, if you can join me.
Yep, I'm here. Can you see me and hear me?
Yeah, can everyone, if you've got a problem seeing us, the best way to view, if you go to the top right hand corner of your screen, and you'll see a little icon that says view, and if you choose speaker view, then you should be able to see us both as we're talking. And if you have any problems, just drop us a shout in the chat box. So thank you so much, Rhian, for volunteering your time.
My pleasure.
It's hopefully going to be enlightening for many people to hear your story. So first of all, can you tell us about your journey to pregnancy, and particularly what advice you received about remaining physically active, given your occupation and your background as an athlete?
Sure. So I actually just had my first child last year. So my baby is 1 year old. But prior to that, I had had 2 miscarriages. The first miscarriage was an ectopic pregnancy, which I didn't even know I was pregnant. So that happened without kind of the consultation of a physician. The second pregnancy, I had an early scan at 8 weeks. The heartbeat was fine. The growth was fine. And at that time, I was advised not to exercise and just to stick to walking and yoga if I wanted. When I pushed for clarity on that, they said it was just a precaution, and that I shouldn't get my body temperature too high, my heart rate too high, or my rate of perceived exertion high. So it was best just to not until 3 months, and then we could reevaluate from there. When I got to the 3-month mark, I went for my scan, and I ended up having a miscarriage. So that pregnancy was not successful. I then tried to conceive naturally for the next kind of 8 to 10 months. And I ended up going through with IUI, and I was successful on the first attempt, which I was very thankful for. And that physician also advised me not to exercise. So he said, because of my age and because of the fact that I had already had 2 miscarriages, he advised that I walk only and wait until the 3-month mark. Even though I had had investigations done in terms of my health and my previous miscarriages, I kind of pushed for more because, you know, physical activity was such a big part of my life, but he was pretty adamant that I should avoid it until at least the 3-month mark. I decided to exercise, and I did not take his advice, and I continued to exercise as normal. And I actually found that it was the only thing that helped, because I had quite a few symptoms early on. I then got to the 3-month mark, everything was fine, and I was advised again not to exercise, this time because of my age and my previous history of miscarriage. For the record, I'm 38, so at the time I was pregnant, I was 37. But I've been physically active my whole life. So I was told kind of by both times not to exercise and to take it easy. Once was because of my age, and once was just as a precaution. But I continued to exercise as I did before I was pregnant. So that's kind of what happened at the start of my pregnancy. Would you like me to continue and just, is Amal still there?
Yeah, sorry, I went and then I arrived again. So okay. I've caught up. So you've spoken a little bit about when you got pregnant and the advice you were given when you were pregnant, and did that change at all after the 3-month mark? Was it a quick snap change, or?
No. So that doctor, he continued to say that I should take it easy because of my age and my previous history. I then went to see a different doctor. I didn't feel comfortable with that advice, and I was seeking a second opinion. And they said I could exercise moderately, and that again, I should keep my heart rate low. I should not get too hot, and I should keep my rate of perceived exertion low. I was doing a lot of research myself, and I, of course, have a fair amount of information in the field. So I continued to exercise as I normally would. At that time, I had severe vomiting. I had severe nausea. I had migraines. I had fatigue. And actually, the exercise was the only thing that helped with that. So I did just kind of continue on as usual. And I felt okay with that. And then at 29 weeks, I actually had a bleed that was quite significant, and I was admitted into hospital. I had to stay in the hospital for 3 days. And that's when they told me I had placenta previa. They gave me very little information. So I was just kind of sent home. And what I was told was if it did not move, I would have to have a C-section. And if I bled again, I might have to go on bed rest. And that's all I was told. So I was given no information about whether or not I could exercise, if I could continue on as normal. So I went home, and at that time, that's when I started to feel quite anxious, and I started to do the research myself. As I'm sure you know, most of the research on placenta previa says no exercise, no sexual. So then I started to kind of really second guess myself, and I got very anxious. I then went to see another doctor, and I had a second bleed very soon after the first one. On that bleed, I was admitted into hospital for 5 days, and then I was sent home, and they told me that I could not then do any exercise for the remainder of my pregnancy. So that was at 31 weeks.
And were you ever guided on what you could do, or was it largely a sort of negative blanket ban on all activities, just lay in bed?
Yeah, so it was pretty negative. They advised me that I could walk and that I could do light yoga, but nothing with a twist or that would get my heart rate up. I kind of felt like I tried to push as much as I could, just because my activity was so high in the past. But I was just told to be on the safe side, to take it easy. And that meant just to walk. So I felt pretty frustrated with that. And then after the second bleed, when I was told to put on bed rest, they actually said that I shouldn't even kind of walk around. So I asked if I could go take my dogs for walks, and they said no. I asked if I could go to the shop. They said no. So at that time I got pretty terrified that I couldn't even walk up through my own house or to the store. And then that's when I went to the private sector to get another opinion. And that physician said I could exercise moderately. He advised me I should not run. I should not do anything high intensity or high intensity weights, but that I could continue to cycle, to walk, to do yoga, and to do moderate forms of strength. So that was the first time, kind of at 31 weeks. And it was completely different to what I had just been told about being on bed rest.
And obviously you likely were experiencing a lot of anxiety as a result of experiencing a bleed and 2 bleeds in your pregnancy, regardless of everything that had gone on beforehand. So in an entire sort of holistic view, I can imagine you would have been experiencing very high levels of anxiety. And how did that inconsistency of information impact upon those feelings of anxiety? Did they have an impact?
Yeah, so my anxiety went through the roof at that time. I was running a business that was being heavily impacted by COVID. So COVID this was right before the lockdown in March. So the first one. So the pressure of that, and then not being able to exercise, and then the fear that I felt from some doctors saying I can't even walk up my stairs, to some doctors saying, no, I can. I just started to get in my own head, and my blood pressure went up quite significantly. And then I actually had a third bleed. And then I was admitted to hospital, but then I was told that I had to stay in hospital until my due date. And I did. And that's when they were very harsh, and I couldn't even, like, they caught me once going outside for a walk, and the doctor was not happy with me. They were like, you have to stay in bed. I mean, it was very strict. And I was in a terrible state. My headspace was terrible. I was anxious. I started to get more tired. My back started to hurt. I felt like my blood pressure was getting higher. I mean, it was very negative for my physical and emotional well-being to be in hospital on bed rest.
And I spoke about, in my presentation, the prescription of bed rest often being exclusive of any other recommendations to, for example, maintain as much muscle strength as you can during that period. And were you, I mean, I appreciate you come from a health and fitness background, but were you given any information as to how you could do the best you could with the situation you had at the time?
So I was given a handout of exercises I could do, but they were all from the laying down, so from prone. So it was like to roll my wrists and to roll my ankles and to roll my head, and that was it. So I mean, I just didn't really think that was enough or something that I did at all, because I just didn't take it seriously. And actually, after the third week of bed rest in hospital, the doctor who had said I should stay went away, and the on-call doctor said I could go home because he was comfortable with me being on bed rest at home. So I went home. But it was so opposite. I mean, every doctor I spoke to had a different level of confidence around the subject. Some were very strict on just being safe, so doing as little as I possibly could. And some, like this one who works more in kind of maternal health and exercise, he was more confident that I could go home, and that it would be good for my health if I went home. Oh, Amal, I think you're frozen.
Rhian, I think we've lost Amal temporarily.
Yes.
Rhian, was there anything else you wanted to share with our audience about those experiences?
I guess just from the patient point of view, it was a really anxiety fueled time. I felt that instinctively moving made me feel much better. Instinctively, when I was less active, I felt far worse. My anxiety was worse. And I think it's really important, if you're unsure of the up-to-date guidelines, to maybe just even say that, and to have some referrals on hand of people who maybe are more kind of focused on the field, so that the patient can get some individualized care and advice, because I do really think that it significantly had a negative impact on my health, both my mental health, and then also the recovery was kind of the same thing. I'm not sure if you wanted to talk about that. I see Amal is back now.
Yeah, I'm so sorry, everyone. And thank you, Eleanor, for jumping in, and for Rhian for continuing. I just had one final question, because I think it nicely shows the dichotomy or paradox in the advice that you have been given throughout your pregnancy and postpartum period. But, you know, at the point you had your baby, and thankfully she was safely delivered, how did the advice on returning to being physically active compare to that you were given during pregnancy?
So I thought that was wild, because they were very casual. My surgeon and the other doctor who I saw on call was just like, yeah, you're totally fine. 6 weeks, come for your check, and then you can do what you did. And so I run a lot. I do a lot of high intensity work. They said I would be totally fine to train. I then sought out the advice of some physios who specialize in postpartum care, and they said absolutely not, minimum 3 months, and really having to build and work on the recovery. So I found it very odd that the return was so casually looked at, and there was just a huge lack of information about how to return to physical activity, not just how to return to activity. Because again, the advice I was given in the hospital was a handout on kind of like how to lift my baby, and that's about it. And then there was nothing else except you're totally fine. And I just was not fine to exercise, and I couldn't actually run until month 5. So, but I was told I could run at 6 weeks, but I mean, I couldn't.
Yeah, and I think that just picks up on what Hayley was presenting on in terms of the return to running guidelines, and that seems much more a normal trajectory than often that 6-week green light is. And I think, you know, obviously your story highlights the experience of someone who is usually very active. And of course, the flip side is that we also want to ensure that we're appropriately informing people who aren't necessarily as active as you, or even anywhere close to the fact that there can be benefits to very even low intensity physical activities. So I think especially that experience of your admission to hospital particularly is a really important one to reflect on.
Well, I also think that, I mean, I'm someone who's very confident with fitness and with the knowledge and background and my level. So, and I was so anxious. And so I think that if someone didn't have the level of confidence that I had, they just would have been sedentary their entire pregnancy. And I think that's very bad for both maternal and fetal health. So I think, like, I forget which speaker was saying it, but women tend to err on the side of caution because obviously it's such a delicate time. And if there's confusion at all, I think usually people would just stop, just so they're, and especially when the doctors are saying just to be on the safe side, you feel like if something happened, it would be your fault. And so it's just quite intimidating too.
All right, thank you very much. Amal is having internet challenges. I'm having a few post-pregnancy reality challenges here as well. It's nearly 9 o'clock. It's been a fascinating evening hearing everyone speak, and especially Rhian, your personal perspective there has been brilliant to hear. Thank you for sharing. We've had quite a few questions come through. Just for a few minutes, I'm going to pick out a few. I've kind of bunched them together. There are a few themes. A first one is around the use of PARMED-X as a screening tool for exercise in pregnancy. Amal or Hayley, I don't know who would feel like speaking on that.
Was there a specific question about the use of it?
Just thoughts on nothing specific. Is it worth using? Is it valid and relevant, or would you use something else?
I mean, obviously, Amal's the doctor. I'll let her come in. But what I would say is, from a fitness perspective, from a fitness professional perspective, one of the big barriers that we know is that women will go and ask their local instructor whose class they usually go to, or their personal trainer, and in a similar way to healthcare professionals, that individual may feel reluctant to say, yes, you're absolutely fine, come and join my class, come and join my workout, because they're worried about that safety. And having something like the PARMED-X is really reassuring to the fitness professional that actually they've had a medical professional look at whether there are any good reasons for that woman not to be active or to modify her activity. And if the medical professional signs off on that, the fitness professional is going to be more confident. In terms of whether it's asking the right questions and giving the right advice, that's definitely something for Amal to comment on if her internet's working.
Honestly, I can't explain why it held out for my talk and then not for anything after. As far as I'm aware, the PARMED-X for pregnancy has been superseded or succeeded by the Get Active for Pregnancy questionnaire, which has also come out of the Canadian group. And whether that is widely available yet, or it's currently under consultation, I'm not fully aware, and I think it's either been published for use or it's in publication. So essentially I would keep an eye out for that, because it will have been updated to improve the utility. I think sometimes screening can be an added barrier, unnecessary barrier, because essentially what we're trying to move towards is encouraging all pregnant individuals to be active. But I appreciate, having presented on contraindications, that's a slight contradiction in itself. But on the whole, most pregnancies are healthy, and most pregnant individuals should be encouraged to be physically active. If you feel you want to use something like the Palmed X, absolutely, it's useful. It will absolutely ask all the relevant questions that you need to ask, as you would with a non-pregnant individual with the PARQ. So yeah, I haven't used it myself, and I think it's a bit of a lengthy form. Someone says it is ready and available to download. Perfect, thank you, Michael.
Great, thank you. I'm just going to pick out a couple of things that I think are going to be pertinent from the questions. There are quite a few questions on the infographics and the guidelines, in particular about clarifying how we classify moderate and intensive exercise when we're talking to women, how they know what's moderate and what's intensive. That's something for Hayley or Amal to pick up.
I don't mind if I think Hayley may be busy. So I mean, it's generally the same as anybody. Currently, the guidance for moderate would be the talk test. So as long as you can speak whilst engaging in that activity, then it would be classed as moderate intensity. You shouldn't be able to sing, but you should be able to speak a sentence, essentially, whilst you're undertaking the activity.
Yeah, sorry, I totally agree. I struggled to get off mute. Sorry, I don't quite know what happened, but thank you.
There's also a recommendation of heart rate ranges. I don't know, Hayley, if you want to talk about that.
I don't tend to use it in terms of a heart rate range. In all honesty, it's more of a talk test, and the types of activities that we work with, it does tend to be very sort of moderate. I don't work with many people that are doing high intensity. So yeah, sort of talk tests and perceived exertion is generally how we would refer to moderate.
Thank you. And then the other question around the guidance is whether it differs following C-section, or whether because it's not time orientated, it's more philosophically and target orientated, whether it can be used in the same form.
Yeah, I think essentially it can be used because it's very tailored to the individual and their recovery and their signs and symptoms. So I was just reflecting on what Rhian said about the 6 to 8 week check, because that did sort of set fear in me that that's not the clearance to then go back and to go off and do the 150 minutes. It's the signs and the symptoms and how the woman feels and how she's progressing that sort of allows that tailored recovery. So I think it fits in with that progression.
Super, thank you. And then just a couple of questions around types of exercise and cautions and things. So one around avoiding overheating, very specific question for people who are in hot countries like Malaysia, 40 degrees C. Would your exercise advice change, or how would you advise them to cope with the heat?
I'm happy to take that one. So essentially, the really important time, so that there'll be an important time that needs to be acknowledged, which is usually quite difficult for people to pin down. So often they don't know they're pregnant at the time, is around 8 weeks when neural tube formation is occurring. And at that point, it's really important that the duration of any activity in environmental temperatures that are high and it's very difficult to sweat and dissipate heat, that those are avoided. So prolonged exertional activity. And obviously any environmental temperature will impact the intensity and perceived intensity of the exercise undertaken. So it's about choosing your environment, remembering the power of spending less time being sedentary, simply being less sedentary, and engaging in your activities of daily living, fatigue allowing, symptoms allowing, and adapting around what you perceive to be too hot, or impacting on your intensity levels to cause you to feel like the exertion is moderate or beyond, because of course that's the only marker that we can reasonably go by is that sort of perceived exertion. Even though it's not demonstrative of heart rate, it's the best reliable marker of what intensity you're working at. In terms of actually exercising in the heat, there'll be an adaptation in individuals who live in hot, humid countries anyway. So it will be very different for pregnant me to go on holiday and then start choosing to exercise in the heat in a different country. But if it's something you're acclimatized to, and whatever you're doing is not causing you to perceive you're working at a higher rate than moderate intensity, if you are beyond that 8-week mark, and you're not doing anything high intensity for prolonged durations, then it should be safe if you're fueling and drinking enough water.
Super, thank you. And then last question, regarding advice about supine and right side lying type exercises, particularly in later pregnancy, which weren't talked about specifically around the guidance. I don't know who would like to take that one.
I don't want to jump on it in
Lou?
case anyone else. No, she's shaking her head.
Lou doesn't want it.
I just think Amal, I'd just like to hear Amal say it because I trust her.
Well, you'll probably say exactly the same thing. In that, again, the marker, it's not an activity that we should exclude automatically. It's just practically as the bump increases in size, as gestation progresses, the chance that the inferior vena cava will be compressed by the gravid uterus increases, and of course gravity will exert that compressive force in a lying supine position. The marker that you need to watch out for is symptoms of dizziness or discomfort. I mean, sometimes it won't be frank dizziness, it might just be a symptom of malaise, at which point change position. All exercises and positions can be modified throughout pregnancy, so that if a class or an online video, or you just happen to be in a lying position, you can modify those positions using bolsters, Pilates balls. Side lying reduces the compressive force to about 25%, and that's right side lying. Left side lying will reduce it even more, but of course a more upright position is better. So they're not excluded activities, it's just a recommendation to be mindful of any symptoms. And certainly all the evidence that we have comes from studies that have been exercise intervention studies that have only incorporated some supine activity within a more global activity program. So we don't have any data that necessarily investigates supine activity acutely or chronically in isolation, only in and amongst other activities performed. And from that evidence, we can say that generally it's safe and doesn't seem to have an effect, but it's not the most well-designed study to give us that answer. Sorry, long-winded.
Anything you want to add, Lou?
I completely agree. And I think the key point here is exactly what Amal said at the start, which is for any exercise that you might think about doing supine, there is always an alternative. So it's very different in terms of a piece of advice compared to the advice that sort of says, you know, don't be active. So there should be plenty of ways that you can replicate the same you know, training load and the same training effect, just with an alternative exercise. So it's a kind of, well, if there is a potentially less risky option, then why not take that option, as opposed to, you know, some of the things we were talking about earlier, which was basically being active versus not being active, where there's a clear downside to the advice saying don't be active. So yeah, so just seek out all of those alternatives, and you can enjoy lots and lots of different activities that don't require you to do that, if that's something you're worried about.
Thank you. I think on that, I'm going to draw things to a close. It's a little bit after 9. Thank you to everybody who's attended this evening. I'm sorry we're a little over time, but it's been so interesting to hear all our speakers have had to say and get through some of your questions. It's been a fascinating evening, so thank you. And thank you to Esther and Chris from the NCS SEM for organising this, and to Simon at the Institute of Sport, Exercise and Health in London for co-hosting this evening. And Hayley, Lou and Amal, thank you for speaking so eloquently. And to Rhian for sharing your story so brilliantly. It really brought to life what we're all talking about this evening. So thank you. Enjoy the rest of your evening, and good night to everybody.
Thanks, Eleanor. Thank you all.
Thank you.
Thanks very much. Bye-bye.